Hello everyone. Let us discuss briefly about the various skull abnormalities and craniosynostosis. It makes sense to first start with the neonatal skull. Parts of neonatal skull and its abnormalities, especially anterior fontanelle, are very frequently asked in NEET PG exam as well as FMG exam. So this is the normal structure of a newborn skull. We are looking from the top. This is anterior and this is posterior. So this is posterior one is the back one. So we are looking from the top, right? So interiorly we have the metopic suture. It is also called as frontal suture. We have two lateral sutures, right and left coronal sutures. Then in the midline we have the sagittal suture. Then posteriorly we have again two lateral sutures called as lambdoid sutures. These are the major sutures that you need to remember. Now the skull bones in a newborn are not tightly fused with one another. There are gaps in between. This is because the head size needs to increase and there should be space for the brain growth. This naturally results in certain places where the bones are deficient. The bones are not fusing with one another. Such places, if they are prominent, they are called as fontanelles. Fontanelles are kind of windows. So there are two important fontanelles that you can clinically palpate in a newborn. That is anterior fontanelle, as you can see here, as well as posterior fontanelle. Anterior fontanelle is this diamond shaped space which is present, whereas posterior fontanelle is a posterior small triangular space. So what are the things that we should remember about these fontanelles? So first of all, we'll talk about anterior fontanelle. Anterior fontanelle. What is anterior fontanelle? It is a diamond shaped space which is present anteriorly in the skull. So the shape is diamond shaped or diamond like shape. What is the size at birth? At birth the size is approximately 2.5 centimeters multiplied by 2.5 centimeters. So 2.5 in length, 2.5 in breadth. When you measure a anterior fontanelle, you always measure not from point to point, you measure it from edge to edge. This is how you measure. So it is always 2.5 multiplied by 2.5. This is asked in your exams, right? So 2.5 multiplied by 2.5 is the size. Normally, anterior fontanelle is at level. It is neither bulging nor it is depressed. In case there is a problem of bulging or overly depressed fontanelle, it will indicate some underlying pathology. Anterior fontanelle is open in all children at birth, but what is the normal closure time? The normal closure time for anterior fontanelle is 12 to 18 months. If it is still open beyond 18 months, that is called as delayed closure of anterior fontanelle. Now there was a question asked once in entrance exam. All of the following sutures contribute to the formation of anterior fontanelle except. So what are the sutures which are directly related or forming the anterior fontanelle? So if you look at the structure, you will find that there are three sutures. They are named as, the mnemonic for that is SCM. SCM stands for sagittal suture, coronal suture and metopic suture. Metopic is also known as frontal suture. So which suture does not contribute to anterior fontanelle? Lambdoid suture is not directly related to anterior fontanelle, and so this will be your answer of choice. So this is regarding the normal structure of anterior fontanelle. Now what are the abnormalities related to anterior fontanelle that we need to remember? First of all, normal closure time is 12 to 18 months. There is a thing called as delayed closure of anterior fontanelle. Delayed closure is said if beyond 18 months it is still open. The common causes of delayed closure include, first of all, delayed closure can be idiopathic. Many times no cause can be found. It can occur in rickets because the bones are not growing. The skull bones are not growing and fusing with one another. It can be a feature of hypothyroidism. It can be a feature of protein energy malnutrition. It can also be seen in achondroplasia, and it can be seen in other bony abnormalities like osteogenesis imperfecta. There is a huge list given in the books, but these are the important ones that you need to remember. Secondly, we have premature closure. Premature means if it closes before 1 year of age. Normally 12 to 18 months is the range. Suppose there is a child, anterior fontanelle closed at 7 months. So that is premature closure. Premature closure is seen in a group of conditions called as craniosynostosis. We will be discussing craniosynostosis in full details in some time. Then we have causes of depressed anterior fontanelle. It is overly depressed inside. So depressed anterior fontanelle will be seen in dehydration. It is one of the useful signs in infants with dehydration. And then we have bulging anterior fontanelle. Now bulging anterior fontanelle, see, there are no bones present below the anterior fontanelle. So any rise in the intracranial pressure in the brain will be transmitted outside, leading to bulging of fontanelle. Transient bulging can sometimes be seen in forceful cry by the child. So if the child forcefully cries, it can produce bulging anterior fontanelle. More commonly, it is due to pathological conditions involving CNS problems. So it can occur in hydrocephalus. Hydrocephalus can cause bulging fontanelle. It can be seen in CNS hemorrhage. So all those conditions which are causing raised ICP. It can happen in CNS infections, etc. So these are the group of abnormalities seen associated with anterior fontanelle. Finally, anterior fontanelle is the last fontanelle among all fontanelles to close. There are 6 to 8 fontanelles which can be seen in a which are present in a child at birth. However, only 2 of them are clinically palpable. Rest are detectable only on antenatal ultrasound or when you do CT and MRI. So anterior fontanelle is the last one among all to close. This is your MCQ point. So this was regarding the anterior fontanelle. Regarding posterior fontanelle, there is only one thing that you need to remember. What is the normal closure time? It is either closed at birth or closes within 2 months of birth. So the normal closure time for anterior fontanelle will be 0 to 2 months. And the size of posterior fontanelle is, in a normal child, it is always less than 0.5 centimeters. So this is regarding the 2 fontanelles and their related MCQ points and one-liners with the reasons. Let us now move our attention to the abnormal head size that we find in children. Now, an abnormal head size can be divided into either it is a large head or a small head. Large head will be called as macrocephaly, small head will be called as microcephaly. The first topic we'll be discussing in the abnormal head sizes is macrocephaly. Macro means large head. So what is the definition? Whenever the head circumference of a child, also called as occipitofrontal circumference, if it is more than +2 standard deviation of the mean. So you plot on a graph, you take the measurement and then you plot on a age related chart. If it is more than +2 standard deviation of the mean, we say it is macrocephaly. What are the common causes of macrocephaly? First of all, it can macrocephaly, large skull, large circumference, can be due to large brain. We call it as megalencephaly. The underlying brain is big in size, so the head is big in size. So underlying brain big does not mean it is a very intelligent child. Some of them may actually be having some degree of neurological dysfunction. So what are the common causes of megalencephaly? Megalencephaly can be seen in the following conditions. Megalencephaly can be benign familial megalencephaly. No reason, just that large head is running in the families. It can be seen in certain neurocutaneous syndromes. Neurocutaneous syndromes we have discussed separately as a proper topic. So conditions like neurofibromatosis and tuberous sclerosis can sometimes have a large brain. It can be seen in Soto's syndrome. It can also be seen in Fragile X syndrome. Fragile X has a large brain but the children are having an intellectual dysfunction. It can be seen in leukodystrophies like Canavan disease and Alexander disease, and both of them are AIMS MCQ points. Finally, it can also be seen in storage disorders, storage diseases like Tay-Sachs disease, mucopolysaccharidosis, and GM1 gangliosidosis. So first we have Miguelin-Kefli as the cause of macrocephaly. Second, it can be seen in patients who are having hydrocephalus. So due to increased CSF, the sutures will separate from one another and the overall dimensions of the skull will increase. So that is hydrocephalus. Third, it can be a feature of overly thick cranium, which can be seen in certain bony disorders. Thick cranium causing this can be seen in patients with achondroplasia, thalassemia major, as well as osteogenesis imperfecta. Fourth, it can be seen whenever there is bleeding in the brain. So hemorrhage like subdural hemorrhage, extradural hemorrhage, subarachnoid hemorrhage, they all can cause increased size of the skull. So I'm just reading short form, you can easily write down, you know the full form of these. Then it can be seen in hypervitaminosis A. Hypervitaminosis A. It can be seen in lead poisoning. It can be seen in intracranial mass. For example, an abscess or a cyst or a brain tumor, and finally in a child. And finally, it can be seen in long-standing galactosemia. Again, MCQ point. So these are the common causes of macrocephaly that you need to remember. Now let us move our attention towards microcephaly. Microcephaly is a group of conditions in which the head size is smaller in size. It is said to be there when the head circumference is below -3 standard deviations of the mean. So a very useful point. Macrocephaly is +2. Micro is not -2. Micro is -3 standard deviation of the mean. So this is one point that you must remember. People get it wrong in the exam. What are the common causes of microcephaly? Most of the causes are primary microcephaly. Primary microcephaly, the causes can be given by a mnemonic which is as follows. Why Dr. Russell Peter can't see ejection fraction in child. Why Dr. Russell Peter can't see ejection fraction in child. So all these first words in them stand for the common causes of microcephaly, that is primary microcephaly. So we have W, D, R, P, C, S, E, F and again C. The W stands for Williams syndrome. D stands for Down syndrome. R stands for Rubinstein-Taibi syndrome. P stands for Patau syndrome. First C stands for Cry-Ducat syndrome, which is a partial deletion syndrome. Then we have S, which stands for Smith-Lemli-Opitz syndrome. Next, E stands for Edwards syndrome. F stands for familial. Sometimes it runs in the families. And last C stands for Cornelia de Lange syndrome. So these are the common causes of primary microcephaly in a child. Then we have secondary causes. Secondary causes, there will be an underlying reason why the microcephaly is developing. Secondary will be seen in congenital infections like congenital CMV, congenital rubella. Rarely it may be seen in congenital toxoplasmosis also. See, congenital toxoplasmosis can have hydrocephalus or microcephaly, but not both together. So it may be a cause of hydrocephalus as well. Then it can occur in maternal alcohol and maternal smoking. It can be seen in maternal phenylketonuria. It can occur in childhood infections like meningitis and encephalitis. It can occur due to birth asphyxia. It can be seen due to protein energy malnutrition. It can be seen in uncorrected hypoglycemia. And progressive acquired microcephaly can be seen in 3 syndromes which are secondary causes, where it is not present at birth or in the first few weeks of life but gradually develops later. So there are 3 syndromes which I am writing with a different colored pen, very frequently asked. You have Rett syndrome, you have Angelman syndrome, and you have Seckel syndrome. So these have late onset. They are called as causes of late onset secondary microcephaly. They are usually discussed separately. So this finishes the discussion of macro and microcephaly, the abnormal head shapes. Let us move our attention to the next thing that is important for your exams, that is craniosynostosis. So the topic we'll be discussing is craniosynostosis. Craniosynostosis refers to a group of conditions where there is premature fusion of one or more skull sutures. So when skull sutures close prematurely before their time, the condition is called as craniosynostosis. It is of 2 types. We have the primary form and we have the secondary form. In primary form, the pathology, the defect is in the skull bones. Whereas in secondary form, there is defect in the underlying brain. Because the brain is not growing, so there is a secondary craniosynostosis which is developing. So we have primary form where the bones themselves are defective, and secondary form where underlying brain is causing the development of craniosynostosis. It most commonly affects which suture? It most commonly affects sagittal suture. This is your NEET PG as well as FMGE MCQ. Now in PGI entrance exam, when it used to be held, there was always a question very frequently asked, what are the syndromes associated with craniosynostosis? PGI exam separately is not held, but now INI CET is an exam which incorporates certain elements of all the Central Institute exams. So for your Central Institute exams and even for NEET PG exam, you need to remember what is the cause, what are the reasons for development of this craniosynostosis. Remember that around 80 to 90% of craniosynostosis, they are sporadic. They are not associated with any syndrome or genetic basis, whereas 10 to 20% are found to be syndromic. So the question arises, what are the common syndromes which are associated with craniosynostosis? Let us write down the names. We have the common syndromes, relatively common syndromes like Apert syndrome, Crouzon syndrome, Carpenter syndrome, Pfeiffer syndrome, Shortzen syndrome, Antler-Bixler syndrome, and finally Muenke syndrome. There is a huge list, but they are the important ones which have been asked in the past and you are supposed to remember. Let us form a small table related to the various types of morphological types of craniosynostosis. On one side, we will write this suture which is involved. In the middle, we will write the deformity which is produced because of that suture getting involved early, and what are the features that you need to remember. They will be a potential MCQ one-liner points. So first of all, we have the sagittal suture. Sagittal suture craniosynostosis produces a shape of skull which is called as dolichocephaly. Dolichocephaly is also called as boat-like skull. It is also called as scaphocephaly. Doll-like skull or boat-like skull. So, boat-shaped or doll-shaped skull. This is the most common type of craniosynostosis seen in almost more than 50% of these individuals. They have increased anteroposterior diameter and decreased biparietal diameter. So, anteroposteriorly they are elongated, biparietal diameter is decreased. So, it is an elongated skull in the anteroposterior line. 80% of them are found to be males. Then we have coronal suture. Involvement of coronal suture, if it is unilateral, that produces unilateral plagiocephaly. Whereas if it is bilateral, that produces brachycephaly. Brachycephaly is the skull which is seen in children with Down syndrome. This is the second most common condition, second most common type of craniosynostosis. Brachycephaly can be associated with trisomy 21. This is your MCQ point. And this is the one in which anteroposterior diameter is decreased and the biparietal diameter is increased. So, it is a flattened skull. It will be flattened like this. Third is your lambdoid suture. If it is unilateral, it produces posterior plagiocephaly, also called as occipital plagiocephaly. If it is bilateral, it produces posterior brachiocephaly because it is present posteriorly. What are the features? It produces ipsilateral flattening of the skull. Then we have metopic suture involvement, the frontal suture. It will produce a triangular shaped skull. It will be pointing in the anterior region, so trigonocephaly. It produces a triangular skull. Then we have multiple suture involvements. When multiple sutures are involved, two patterns can be seen. Either of the two patterns. The first pattern is oxycephaly, also called as turicephaly. This is also called as tower-like skull, elongated tower-like skull. These are the patients who are having raised intracranial pressure. The second pattern is called as clover leaf skull. Clover leaf skull is called by a German name, what we called as Kleeblatt-Schädel deformity, also called as Kleeblatt-Schädel skull. It is also called as trilobular skull. These are the various names of the same condition. Clover leaf skull has again high risk of raised intracranial pressure, and it is not a tower-like skull, so raised ICP and hydrocephalus can again commonly be seen. So, these are the two different shapes when multiple sutures are involved. Treatment of craniosynostosis is majorly cosmetic, but it is related to if there is a raised ICP, you need to put a shunt. If there is an underlying or associated syndrome, you need to manage that. Otherwise, in benign self-limited sutures, if they are not causing any problem, they are isolated, many times they need to be left behind as well. So, treatment is not entirely well defined. It varies according to the type, the severity, the coexisting features and the status of that child. So, treatment will not be asked to you in exam. Before we go further, there is a small little thing that you need to remember. There is a differential diagnosis of craniosynostosis, which looks like craniosynostosis, but actually it is reversible. We call it as deformational plagiocephaly. Certain children, they sleep on the same side always, young infants. So, their skull becomes flattened on that side. It produces an appearance as if a craniosynostosis is present, that is called as deformational plagiocephaly. Although you can investigate and find out the underlying cause, but in general when you palpate these children, the skull of these children, in case of craniosynostosis, you will find that there are palpable ridges of the skull. Overlapping palpable thickened ridges can be felt in craniosynostosis, whereas in deformational plagiocephaly, there is no palpable ridges. This usually has a good outcome. Can a therapy be used? Yes, there is a therapy called as helmet therapy, which can be used in patients of deformational plagiocephaly. It is a close differential diagnosis of craniosynostosis. And before we finish this module, there are two syndromes sometimes can be asked in exams, particularly in Central Institute exams: Apert syndrome and Cruzon syndrome. You should know what are the key features of these two and how they look like, so that if a spotter or visual is asked, you are able to identify. Let us first look at Apert syndrome. This is the photograph of a child with Apert syndrome. Apert syndrome is a condition in which there are multiple abnormalities, most of them arising due to fibroblast growth factor receptor 2 mutations, although sporadic cases and other genetic involvement has also been described. Apert syndrome is characterized by a triad of three things. First feature of Apert syndrome is craniosynostosis. The common craniosynostosis which can be seen in them is brachycephaly, although scaphocephaly can also be seen. The second feature of Apert syndrome is mid-face hypoplasia. Can you see in this child that there is a mid-face hypoplasia? The middle part of the face is hypoplastic and depressed inwards. And third feature of this is bilateral complete syndactyly. All the fingers of both the hands are fused. These hands which are produced are called as mitten hands. Look at this child. This is a classic case of Apert syndrome. Look at this mid-face hypoplasia. Craniosynostosis obviously will require investigation and examination. And look at these mitten hands. There is bilateral syndactyly present. Always think of Apert syndrome. This is how Apert syndrome typically looks like. Classically speaking, Apert syndrome, there is no proptosis. There is no proptosis in Apert syndrome. The second syndrome, which is often confused with Apert syndrome but is different, is Cruzon syndrome. This is a child with Cruzon syndrome. What are the features of Cruzon syndrome? First of all, they will have craniosynostosis. The craniosynostosis in these children also is commonly of brachycephaly variety. So they have brachycephaly, that is flattened skull. Secondly, they will have, as you can see in this child, severe prominent proptosis, which is not the case in Apert syndrome, right? Third, they will have strabismus of the eyes, right? Fourth, they will have a hooked or beaked nose. The tip of the nose will be pointing forward or downwards. So beaked nose will be present. Although beaked nose cannot be easily made out, but it is frequently present. Fifth, they will have high risk of developing having Arnold-Chiari malformations. They may be associated with Chiari malformations. And finally, they may have some degree of mild prognathism. That is, the lower jaw can sometimes show some forward protrusion. Mid-face hypoplasia is very mild or it is usually absent. So this is a patient who is having Cruzon syndrome. So this finishes our discussion of abnormal skull shape. We started with neonatal skull, talked about abnormal sizes, discussed few points regarding the fontanelles, and finished with craniosynostosis, its DD and related syndrome.